Welcome to More Than Numbers, a series presented by ICES where we're going to take a deeper look into how data is used to answer important healthcare questions in Ontario. Since 1992, the Ontario government has entrusted ICES with securely holding and analyzing its health administrative data to evaluate and improve Ontario's health system. Our researchers use a vast and secure array of health-related data to answer key questions to improve the health of Ontarians. Mental illnesses are health challenges that can affect how someone thinks about themselves, relates to others, and interacts with the world around them. The Mental Health Commission of Canada states that in any given year, 1 in 5 people in Canada will personally experience a mental health problem or illness. Historically, stigma and discrimination attached to mental illnesses present barriers to individuals seeking care, getting diagnoses, and treatments. The Mental Health and Addictions program at ICES uses population data to understand how life transitions, from adolescence to adulthood and other transitions, as well as environmental changes, affect the development and manifestation of mental health and addictions problems. To take a more in-depth look, we connect with ICES scientists from the Mental Health and Addictions program. Dr. Paul Kurdiak, who is a program lead, senior scientist, and a psychiatrist, as well as Dr. Elaine Tulani, who is an adolescent medicine specialist and ICES fellow. How has this change impacted mental health and addictions research and the mental health care system as a whole?
Historically, mental health has been highly stigmatized, and this stigma has contributed to some of the long-standing challenges we see in the mental health care system. So things like lack of coordination, limited capacity of the system, and the resources available. And as an adolescent medicine specialist, I am witnessing firsthand a growing knowledge and destigmatization of mental health issues among my adolescent patients and their families.
I have been a psychiatrist since I finished my training in 2003. And in those 18 years of my practice, I have seen an incredible change in the way that the public speaks and thinks about mental illness and mental health. Every day, I think it seems now that there are stories in national media about mental health and mental illness. And I think that this is part of a massive public destigmatization related to mental illness. And I think that this is just an incredible and important process and social phenomenon. And I feel like we are working in our team in parallel with this destigmatization by shining a light on the mental health system and contributing to the broader debate. Now that the public is willing to discuss openly what it means for us as a society to deal with mental illness, we are very proud to be contributing really solid evidence and essentially making the invisible visible to contribute to that debate.
As more young people enter the mental health care system, it's a bit of a double-edged sword because the system is not yet ready to meet their increasing needs. One of the important success stories of research coming out of our mental health and addictions program at ICES is that we have unearthed some of the difficulties patients face in navigating and accessing the mental health care system. Many individuals don't know how to get help or where to go for help. And to be honest, as a clinician working in the system, I too find it difficult to navigate. There's no consistent or clear pathway that I take for my patients to help them better access mental health care. It's like I'm doing it for the first time every time.
As mental health and addictions are becoming more publicly discussed and destigmatized, it is evident that there are many unmet needs regarding mental health care and access, which have enormous consequences for individuals and their communities. Data can help shed light on these gaps in the system. How does ICES obtain data on mental health and addictions, and why is access to this data so necessary?
Our ICES Mental Health and Addictions Program team uses similar data and methods as other research programs in our institute. So when a patient visits a physician, such as a family doctor or a specialist, if they go to the emergency room or if they get hospitalized, that information comes to us as administrative health data.
For the most part, we get feeds from the Canadian Institutes for Health Information, CIHI, and from the Ministry of Health. And we have, as a team, developed standards and protocols to kind of extract the mental health and addictions related components of that. So we know how to like reliably and accurately get primary care physician visits that are mental health and addictions related versus non-mental health and addictions related. What's different about our work is that we drill down on the mental health and addictions facet of those types of care. So, for example, we have developed a reliable and accurate way to determine what type of primary care physician visit is mental health and addictions related. We have identified ways to use the diagnostic codes in the emergency department data and the hospitalization data to parse out what aspect of those types of health service utilization are mental health and addictions related or not.
The data that we do have has allowed us to change how we as clinicians, as well as the public, is talking about mental illness. So for example, our data has shown us that for many patients with mental health issues, especially the youngest patients, their first point of contact with the healthcare system is through the emergency department. And this is different from what we see in other populations and sectors. This indicates that there may be inadequate access to mental health support and care by physicians and community-based services. So patients and families don't have any other choice but to go to the emergency department for help.
There are a couple of other areas where we are highly invested and interested in pursuing. One is this community-based care. We know in Ontario that every year the Ministry of Health funds a substantial amount of mental health and addictions care that occurs in community settings that is not reporting into our normal data sources. Many of these agencies do collect data and report on it, but it's not routinely sent to ICS. So it's invisible to us, and yet there are important contributions to the totality of mental health care that's being provided across Ontario. So some of our holdings that reflect the community side of things are DATIS, and that refers to the Drug and Alcohol Treatment Information System. And what DATIS is it's a similar type of data source as we get at ICES, except that it is capturing when people access one of the over 180 Ministry of Health funded community-based addiction agencies. So to be able to get a window into what's happening in all of these publicly funded addiction agencies across the province will be a huge opportunity for us to understand in a much more granular way what's happening in terms of addiction treatment. More locally, we've worked with Community Business Intelligence, or CBI, which is Toronto Central LIN, or formerly Toronto Central LIN, source of community-based data, which captures all of the ministry-funded or LIN-funded mental health and addictions agencies in the Toronto Central LIN. So it's an opportunity to learn more about what's happening in the broad base of community agencies that we know are so important to the broader sort of delivery of mental health services that prior to these linkages have been invisible. The other area that we're really interested in developing further relates to the fact that so many people who have mental illnesses or addictions also have very significant issues related to social determinants of health. What I mean by that is that we know from our work that by virtue of having a mental illness or addiction, you're much more likely to reside in a low-income neighborhood. You're much more likely to be racialized. Actually, some of our work has shown some striking and kind of tragic findings related to racialized populations and outcomes. And we know that through work with Dr. Fiona Kuyumjian, that people with mental illnesses and addictions are tragically overrepresented in correctional facilities or jails. Through work with Fiona, we've been able to show that 70% of individuals who end up in Ontario correctional facilities or jails in a given year have some history of mental illness or addictions. And this is a staggering number to me. But now that we know that, we're very interested in disentangling whether or not there are ways for us to improve upstream interventions.
There are a lot of services for mental health and addictions throughout the system, but only some of these services are publicly provided, which means that we cannot capture the data that are not publicly provided in ICS's dataset. We can also only see individuals once they interact with the healthcare system and seek care. To get a full picture of the mental health system, we also need to know what the data does not capture. What are some of the limitations of the data available for the mental health and addiction sector?
The health administrative data available to us at ICS has some important limitations, and we have to be clear about what it can and cannot tell us. Mental health care that is provided by physicians is captured by our data, but we don't know about the mental health care that's being provided by other clinicians, such as psychologists and social workers. And we know they contribute a vast amount to mental health care delivery in our province, and we're unfortunately unable to measure those services with our data. Another limitation is that some patients and families may be particularly savvy at navigating the system, or they may enter through another avenue like law enforcement and are therefore more highly represented in the data. Another limitation is that our data are good at telling us what is happening. So in other words, who's using care, how they're using care. But the question about why this is happening is not answered by our data.
We know that people with schizophrenia are amongst the least likely to receive timely follow-up, physician follow-up after discharge from a psychiatric hospitalization. And that's a fact. It's an irrefutable fact as a result of the data we have. What our data are really limited in is telling us why. We don't know whether people with schizophrenia are less likely to make it to the follow-up appointment because of the limitations they experience as a result of their illness. We don't know whether they are less likely to be provided with follow-up. We don't know whether there are circumstances or deficiencies within the discharge process. And I think the other major limitation is that we don't have outcomes. So what I mean by that is we know when somebody gets hospitalized, but we have very little good information about whether people benefited from that hospitalization. We know when people see a psychiatrist. We know when they start seeing them. We know how frequently we see them. We have no line of sight into the details or the kinds of interventions that psychiatrist is providing to that individual, and more importantly, whether that individual is benefiting from those interventions. And so this is an area where it's going to be hard to develop an accountable system of care without those kinds of outcome measurements.
You've discussed that it's difficult for individuals to navigate the mental health care system, and in many instances, each time you see a patient, you have to determine the appropriate and potentially a new path ahead for their care. With a system so difficult to navigate and complex, are you able to see differences or gaps in access to care through your research?
So one of the most critical issues in the mental health sector is access to care. We unfortunately cannot measure wait times, but we know anecdotally that people wait an extraordinarily long amount of time for services. So even if somebody was referred to some type of service for the kind of things they were struggling with, things got worse while they were waiting interminably for services. So we know that even without knowing what wait times for particular services, we know that access is a huge issue. And we have been doing quite a bit of work in this area in particular populations. One of the ways in which we know that access is quite poor is in a new measurement that we developed that specifically maps on to access. And it has to do with the fact that people are probably using emergency departments for mental health and addictions care precisely because there's no other door open to them. And so what we've done is we've taken a look at individuals who come to the emergency department for the first time for a mental health and addictions reason. And because we can link them through to the physician-based data, we can then look back 2 years and see whether they've had any mental health or addictions related physician visit in the previous 2 years. So what we've shown is that among all individuals who are in Ontario who are coming to the emergency department for the first time for a mental health or addictions reason, nearly half of them have had no prior outpatient physician contact. The other areas that are really striking and tragic. We can measure when somebody has an emergency department visit for intentional self-harm, and that's the sort of our formal way of saying somebody's come to the emergency department after a suicide attempt. And we've looked at the rate at which these individuals see a psychiatrist within 6 months. 60% did not. And, as a psychiatrist who works in the emergency department, this was a very troubling finding because this is obviously, by its very nature, a very high-risk population. If we can't meet the needs of these individuals in a timely way, we can't really call ourselves an accountable mental health system. Other work led by Dr. Maria Chu, a scientist in our program, used our ability to identify individuals of either Chinese or South Asian ethnicity and to measure the severity of mental illness or addictions presentations at the time of a first psychiatric hospitalization. And we think this has to do with variable stigmatization in certain ethnic communities in Ontario. And so this is an area where we think that there's probably opportunities for community outreach to encourage people to seek help when they need it.
Individuals with mental illness and addictions interact with so many facets of society to receive care and the services they need. How have you been able to work with other partners and leverage these data to impact mental health and addictions care in Ontario?
Our team is strongly focused on developing strategic partnerships with government and other service agencies to facilitate better data sharing and integration. This allows for more integrated measurement of service provision across multiple sectors, such as education, community youth mental health, and social assistance.
I think one of the unique things about the ICES Mental Health and Addictions Program is the way in which we were founded with an intentional relationship with policymaker stakeholders. We as a team have always had regular contact with our policymaker counterparts within the Mental Health and Addictions Division in the Ministry of Health. We have developed an understanding of their needs, and we've developed a trust bilaterally. Like they trust us to do good work and to be objective, and to not sort of blindside them. And they have had a greater understanding over time about the limitations of our work.
We also know that mental health practitioners and policymakers are using our research data to help guide health service planning, education, and increase awareness about mental health issues. We also are learning from each other. So, for example, our relationship with the Ministry of Health allows us to package our data in a way that makes sense to people who work in government for rapid decision-making.
What's resulted from that is kind of a pivot or shift over time from our approach to our research as being investigator-driven to being a little bit more policymaker-driven. And they come to us with specific questions, and then we try to answer them and generate evidence that can help them in their policy work.
Together, we are also developing new ways to deliver meaningful mental health messages, communication, and education to and with the public.
More recently, there's been a new entity within Ontario Health called the Mental Health and Addiction Centre of Excellence. And this new agency has a mandate to oversee standards and quality within the mental health sector broadly. And this has been very exciting for our program because the implementation side of things of this new agency means that we can work in lockstep. And this is very exciting because this means that our work is not just generating facts, but supporting interventions with outcomes and allowing us to know whether the kinds of things that we are hoping to impact positively on the mental health system are working.
With the societal change in the dialogue and destigmatization of mental illness and addictions, and with people being more comfortable with seeking care, the mental health and addiction system will have to adapt to continue to meet the needs of the population. What's on the horizon for mental health and addictions research in Ontario, and what unanswered questions do you hope to tackle in the future?
Our data describe what is happening at the macro system level and helps to provide signals to where we need to look deeper. This leads us to ask many new and exciting research questions. We want to leverage ICES's frequent data feeds to facilitate improved monitoring of the mental health system, examine real-time trends, and provide more timely research evidence to knowledge users in the sector. Our mental health system is so complex. We want and need to continue to source data from many services to tell the whole patient story and true experience.
One obvious area that we're sort of pivoting into is responding to the mental health and addictions evidence needs during the COVID-19 pandemic. The combination of the prolonged social isolation. Many individuals, have been financially impacted by the pandemic. So there's lots and lots of ways in which we would understand that people are struggling from a mental illness or addictions perspective because of the increased stress associated with it. The other opportunity is in sort of raising the profile of the need for proper mental health and addictions information. Other areas where I think there are really great opportunities have to do with the work that's coming out of the new agency, the Mental Health and Addiction Center of Excellence. The Center of Excellence is overseeing the implementation and expansion of a brand new service in Ontario, which is the delivery of Ontario structural psychotherapy, and this is making publicly available a type of therapy, cognitive behavioral therapy for depression and anxiety related disorders that didn't exist before or existed in patches. In many ways, we're really happy that our existing work is getting great uptake and informing policy, and we're really happy with our stakeholder relationships that we've developed and our engagement strategies. But we also feel like we're just kind of getting started and that we need to figure out ways to leverage what we've built.
The mental health and addiction sector is a complex system, and data is a key element for understanding where care is being provided, but also to unearth the gaps that exist where patients may not be able to access the care that they need. Paul and Alen, along with the Mental Health and Addictions Research Program, are using data to tell the story of the system and the challenges that Ontarians face when they seek care. Behind all of the headlines and statistics, it's important to note that it's more than numbers.